Very good evening to all of you. I welcome you all for yet another What is the Expert session of EOS in India. And today we have another talk on sleep disorders in children with autism. I'd like to request our President, Dr. Shefali ma'am, to introduce the speaker for today, the experts for today's session, and the moderator for today's session. Over to you, ma'am.
Thank you. Thank you very much. Good morning, good afternoon, and good evening to everyone. Asmita, can you share the screen, please? Yeah. So, at the outset, I'll invite all of you for the Asian Oceanian Child Neurology Congress in New Delhi next year. 16th is the pre-conference workshop and 17th to 20th is the main conference. And the abstract submission will be started and registration is on. So you can scan and register. This will be mailed to you all also who are attending the webinar. Thank you. So today we have sleep in autism spectrum disorder, which is very important. And we have Professor Suresh Kottagal, who's Professor Emeritus from the Department of Neurology, Mayo Clinic, Rochester, USA, and he has been a very good teacher for so many of our people, and very grateful that he's joined us. And his area has been of interest has been sleep medicine with focus on childhood narcolepsy and sleep in children with Angelman syndrome. And he has served as director of number of MN annual meetings and twice as a director of a neonatal neurology course and a member of a pediatric working group of international classification of sleep disorders. And he has an extremely illustrious career. We are very grateful that he's joined us. And as experts, we have very good, exceptionally good Dr. Sanjeev Kothare, who spoke last time. And I'm really kind enough to have joined today as an expert. He's Director of Pediatric Neurology Service Line for North Health and Professor of Pediatrics and Neurology at Zucker School of Medicine. And he's editor of Sleep in Childhood Neurological Disorders, Parasomnia, Sleep Disorders in Adolescents, and Associate Editor of Journal of Clinical Sleep Medicine, Section Editor of Pediatric Neurology, over 200 publications and recipients of number of awards and grants. Thank you so much, sir, for joining in the second consecutive session. And Dr. Kothare was the speaking last time, and Dr. Suresh Kottagal was the expert last time. Thank you so much. And thanks for my mentor, Professor Kalra, who needs no introduction to this gathering, who actually pioneered pediatric neurology in India and has been my mentor. And for having joined. Then Dr. Biju Hamid, who's consultant in pediatric neurology and neurodisability in GOSH, currently on a sabbatical to establish neurosciences in UAE, and he's involved with the ICNA. Next, please. Yeah. So next we will be having our moderator, who's Dr. Nitish Vora, who's a senior consultant pediatric neurologist and epileptologist, director of the Royal Institute of Child Neurosciences, Ahmedabad. And he's done his MRCPCH and FRCPCH from UK, and his areas of interest are epilepsy, brain injury, and autism, and has got lots of awards. He's a bright force in Gujarat, but also in India, and a very, a young professional who's on the rise. And I think, Nitish, all over to you.
Thank you very much, ma'am. Thanks for the nice introduction. And we're so glad to have Prof. Kottagal and some experts with us. So without wasting time, can we move to the Prof. Kottagal's talk, please?
Yeah. Asmita, please start sharing the slides. And when sir says, you keep changing. Yeah.
Thank you. You can hear me all right?
Yes, sir. Loud and clear.
Okay. Very good. Thank you. Well, it's a pleasure and an honor for me to be able to interact with so many eminent child neurologists in India and also eminent child neurologists outside of India. And today, we'll just talk for about 45 minutes on sleep disturbances in children with autism. Next slide, please. So the learning objectives are two. Number one is to discuss mechanisms underlying disrupted sleep in children with autism. There are several different mechanisms. And then to provide a clinical scheme for the evaluation and management of this disrupted sleep in children with autism. It's really very common, so we need to have some sort of a scheme to follow to assess. why should we worry about sleep-wake problems in this population? Number one, we know that the children, especially those with autism, if they don't sleep well at night, it affects their daytime behavior, particularly concentration and impulse control, and also their ability to pay attention and learn. Next item, please. And of course, so many children with autism have seizures, and if there's disrupted sleep at night, probably more likely to have a lowered seizure threshold. And if that happens, then you end up using more anti-epileptic drugs, which can have their own side effects. And poor sleep in general has a negative effect on the quality of life. Not only of the child, but also the caretaker. And caretakers, especially mothers, are really under significant stress, and there is a very high degree of burnout simply from caring for the child. And there are significant societal costs. These costs are difficult to estimate. And if you talk about emergency room visits or hospital admissions or clinic visits, and the parent not being able to go to work, etc., all of these add up. And in the US, recently somebody estimated 126 billion per year societal costs. Now, some developmental backgrounds for us to consider before we dive into sleep in autism. And there are two aspects. One is the maturation of the circadian system, and the second is maturation of the sleep-wake system. Circadian, of course, implies it's from Greek sarkadai, or once a day, and day-night rhythms, for example. And the circadian rhythm maturation really starts in the middle trimester with formation of the suprachiasmatic nucleus, which is the circadian timekeeper, maturation of the retino-hypothalamic tract, which projects from the retina to the suprachiasmatic nucleus, or SCN, development of melatonin receptors, and development of melatonin rhythms. And these melatonin rhythms are present in the mid trimester of the fetus, and the melatonin rhythms in the fetus coincide with those of the mother. So mother is asleep, baby is asleep, and likewise. And then, just stay on that for a moment. Let's go back. Yes, thank you. So 0 to 1 month, what happens? Body temperature rhythms develop. 2 to 3 months of age, postnatally melatonin and cortisol rhythms develop. And 3 to 6 months, there is entrainment to the light-dark cycle. So babies are more awake in the daytime and sleeping longer at night. From the sleep maturation standpoint, we know that in the first month or so, there is polyphasic sleep, sleeping, waking up, sleeping up, waking up, and then longer sleep ultimately develops at night. With regard to slow wave activity, which is the delta sleep or activity, say between 0.75 hertz and 4 hertz, that really has very high levels in 2 to 3 months of age, and then they're on in 3 to 6 months of age, and then gradually declines. And we'll talk about the significance of slow wave activity. Next slide, please. Can move to the next slide. Yeah. And then the question is, how prevalent is insomnia in children with autism? Based on parental surveys, the prevalence is estimated between 50% and 80%. This is for sleep initiation difficulty or sleep maintenance difficulty. And you can compare that to this insomnia in typically developing children, which is very less, 9 to 50%. And there are several surveys which have noted this high prevalence. The issue, however, is that there is a parental bias because these are all surveys of parents, and the prevalence rate may be biased by who was asked about it. And is a child who is more cognitively impaired more likely to have a greater amount of insomnia? Not necessarily. There doesn't seem to be any correlation. If anything, perhaps some studies indicate that milder cognitive impairment may be associated with greater insomnia. Perhaps their ability to process and be maladaptive is greater than somebody who's more severely impaired. Next slide, please. Yeah. And then we look at the etiology of the insomnia in autism. Number of factors are really psychological. There's so much anxiety in children with autism about falling asleep because they separate from their parents, and they all of a sudden there's some sensory isolation, and all imaginary thoughts and ideas come in, and they start thinking about things and have a hard time falling asleep or staying asleep. And then there is perseveration. And this is very important because whatever happened during the daytime, it doesn't go away from their mind. They keep, thinking about it over and over again. So, and we'll talk about that in a moment. And then behavioral insomnia syndrome. The child doesn't sleep. Parents will use some techniques which are really maladaptive and makes the behavioral insomnia worse, like sleep onset association disorder, restless leg syndrome, circadian rhythm sleep-wake disorders, REM sleep behavior disorder, which occurs in children, but for some reason it is underestimated. It's not really thought about as much. Because when we do the sleep studies, we don't examine the EMG activity in REM sleep as carefully as we should. Then, of course, there's sleep-related epilepsy itself or its treatment. Now, multiple brain areas can be implicated for insomnia in children with autism. We just hit the button. Let's see. Next. We just hit the next. Yeah. So if you look at a neonatal epilepsy or early infantile epileptic encephalopathy with protocoherent 10 mutations, lesions are maximum in the lateral hypothalamus or pineal gland. Pineal, of course, is the region where melatonin is produced. We look at autism associated with Rett syndrome. There are greater impairments in the locus coeruleus. If we look at, and just hit the next button again, couple more times. Yeah. If we look at serotonin transporter, that is disrupted in the region of the dorsal raphe nucleus, and with Angelman syndrome, lesions are more prominent in the substantia nigra. So different children with autism have brain lesions and different regions of the brain. There is reduced sleep pressure in young children with autism. By that I mean their ability to fall asleep and stay asleep, especially going to deep sleep, is less. And in general, sleep pressure is probably akin to what we call the homeostatic drive to sleep. And the homeostatic drive to sleep is dependent upon prior wakefulness, especially if we stay awake during the day, we are more likely to go into deeper sleep. On the other hand, if a child takes a nap in the daytime, that sort of dissipates the sleep pressure. And that night, the child may not be able to sleep as deeply. And the greater the sleep pressure, the greater the amount of slow wave sleep at night. And just hit the next button. Yeah. And Thank you. So what happens is that when there is greater slow wave sleep pressure, has a positive influence on brain function. So this particular study, Arazi et al. From Ben Gurion University in Israel, they looked at the EEG, overnight EEG, on about 29 children with autism, and there were about 23 controls, healthy controls. Now, how they selected 29 is not clear, because they had a total pool of 200 children with autism, and they selected 29. So, and they don't quite explain how they, please go back. Selected those 29 patients. And anyway, when they did the EEG and subjected the EEG data to fast Fourier transform, they noticed a weaker slow wave power, shallower slow wave slope, decreased proportion of slow wave sleep as compared to controls. So they don't sleep deep as compared to typically developing children. Next, please. And then, of course, is the role of comorbid epilepsy. There are, if you look at interictal epileptiform discharges, they are present in anywhere from 8 to 60% of children with autism. And epilepsy is also very common, occurring in 20 to 30% of children. For the medications, certain medications used to treat epilepsy might contribute to insomnia, especially barbiturates or benzodiazepines or felbamate. Then if we look at agents like, say, carbamazepine or phenobarbital, these, of course, are enzyme inducers, especially inducing P450. Melatonin is metabolized through the hepatic microsomal enzyme P450. So if you give exogenous melatonin, melatonin from the outside, that's the clearance of that may be accelerated by the anti-epileptic drug. Then, of course, we have other factors like melatonin dysregulation, which really is a big deal in children with autism. They may, over a 24-hour period, if you sample blood every 4 hours, they may have overall decreased melatonin as compared to controls. Next item. And then the other issue is that, the greater the difference, normally, the greater the difference between the low daytime levels and high nighttime levels, the better the sleep. But in children with autism, the difference is sort of blunted, so there may not be much of a difference. So as a consequence of that, really, there's difficulty with falling asleep. Third. Next item, yeah. And then sometimes some syndromes, especially Smith-Magenis syndrome, and this is not related just to Smith-Magenis, sometimes even autism undifferentiated can have this. The melatonin secretion patterns are sort of totally flipped. So there is a higher melatonin secretion during the daytime when it's not needed, and low melatonin at night. So that's another issue that can happen. Next slide. Next item. Yeah. Okay. So if we look at melatonin in autism, there's a paper which I thought was a really nice paper, but some people have questioned it, and I will come back to that in a moment. But these folks, Melky et al., they sequenced the exons and promoter regions of the ASMTG. ASMT is essential for synthesis of melatonin. So acetylserotonin, excuse me, methyltransferase. And they noted that as compared to controls, there were two polymorphisms which were seen more frequently in the autism patients as compared to controls. And these polymorphisms were associated with a dramatic decrease in levels of ASMT in the platelets. And just hit the next button again. Yes, thank you. So on the top left, you can see there are several bars, and this is on the top left is the circulating ASMT level, and the first bar on the left, which says C, that's the ASMT concentration in controls. And then next, after that, to the right is ASD1, that's one family, where father, mother, and proband. The proband is shown in the dark black bar. And then to the right is another family, ASD6, father, mother, and proband. And notice that the levels of the black bar is significantly low in the proband. So ASMT levels are low, so they just don't synthesize enough melatonin. And then to the right, there's another that is B, shown as B. And once again, you can see not only is the ASMT level low, the melatonin levels are also low, especially in the proband as compared to the mother and father. So they just don't put out enough melatonin. And now I think the critique of this paper is some folks have said, well, they were not able to replicate the levels, replicate the results. So it still remains to be seen. But I think in general, I would believe, especially when you give melatonin, the response of children with autism is really fairly robust. So it probably stands to reason that this is bona fide. Next slide, please. And then we have behavioral insomnia. And these behavioral insomnia syndromes, I thought I'd just share some cases that I've dealt with over the years. And I'll show you discuss with you an 8-year-old boy with autism with a lifelong history of sleep initiation and sleep maintenance difficulty. I was in Minnesota. They drove from adjacent Wisconsin, about 2 to 3 hours, came to see me. And they had it, they were just totally exhausted because the child was just not sleeping at night. And they would start around 8, and it would take about 2 hours for the child to fall asleep. And I said, well, how does he fall asleep? They said, well, we have to sit in a rocking chair and hold him and rock him. And that's the only way he falls asleep. Once he has fallen asleep, they place him into the bed and they sneak out of the room. But then within a few minutes, immediately the child awakens, and then they have to go back in and repeat the whole scenario all over again. And they fall asleep, lying down, but he wakes up repeatedly at night. Next item, please. Next, yeah. And then, of course, the child is not sleeping, so parents are not sleeping, so they're totally exhausted. And parents exhausted, stressed, child was irritable and emotionally labile. And looked like what we call the typical sleep onset association disorder, where the child had sort of become habituated to receiving, being held and being rocked repetitively in order to facilitate sleep. And the moment they would lie him in the bed, of course, the rocking and holding would go away, and then he would wake up. So it was sort of more of a behavioral insomnia syndrome. And so I suggested, well, don't let him take any naps in the daytime, so that will help building the homeostatic drive to sleep. The sleep pressure will build up, sleep better at night. And then also to have him have more sleep pressure, postpone bedtime by about 30 to 45 minutes. And if you have to hold the child or rock the child, just do it for a few minutes, maybe 10, 15 minutes. And then, very important, I said, the parent should leave the room before the child actually falls asleep. And of course, in general, we recommend some emotional support to the parents too. And so I gave all this advice. And would you believe it? They never came back to see me. Just go back to the slide for a moment, please. Yeah. No, please go back to the previous slide. And what do you think the mistake I did? I think a lot of times when so I'm giving you all this nice behavioral insomnia advice, but a lot of times parents are under the assumption that the doctor is going to run some tests, and they want to be sure that it's not something organic that we are missing. And, I think at the very least, I should have checked a serum ferritin level. And of course, children with autism are notoriously difficult to do overnight sleep studies. And this is a behavioral insomnia syndrome. So I didn't think it was necessary to do a polysomnogram. But I think somehow I gave them the impression that this is all behavioral. And when I say behavioral, parents think that you as a doctor are blaming them, that they are somehow bad parents. So I think it's a very sensitive issue. And I think one has to make sure that they understand you are looking at the organic factors also. You will investigate them to the extent needed. And then I think you can even give the behavioral insomnia advice at the next visit, not at visit 1, because then they will just get turned off. At least that was my learning from this particular case. So while the advice was good, I don't think the timing of the advice was correct. Next slide, please. Iron deficiency, next, keep hitting the bullet points. 12-year-old is another child with severe autism. He was very hyperactive and aggressive. Every time he would come into the office, he would just grab my name badge and try to yank it off. So he was so aggressive, the psychiatrist placed him on risperidone, 0.5 milligrams twice a day, but it was not helping. And he was restless at night with repetitive kicking of the legs. And next slide. But we tried to do a sleep study, but he, it's very difficult. He did not cooperate. But anyway, his serum ferritin level was low, 13 micrograms. And for good sleep, we know that we need the serum ferritin level to be maintained over 50 micrograms. And once again, the family was totally exhausted. And I thought, it's going to take me several months to really boost the ferritin level by giving the medication by mouth. Curiously, this child was okay with blood tests and needles and blood draws. So I've sort of developed the technique in which I've published in, I think it's in Sleep Medicine, giving intravenous iron sucrose, which will immediately boost the levels of serum ferritin. So we gave him IV iron, about 5 milligrams per kilo of iron sucrose, and his levels of ferritin normalized. Next slide. Next item, please. Yeah. And next. Yeah. So his sleep actually became better. Next. And so sleep really got better with the iron application. The point is that iron deficiency is actually very common in children with autism, and about 1/4 of children have iron deficiency enough to disrupt sleep. We don't know exactly why this happens, but one could certainly point to the dietary factors. A lot of times their diet is very skewed, mainly carb-based, and here in the US, kids will sometimes have a fascination to eat potato chips or fries, and that's it. They don't eat anything else. So that's a factor. Next slide, please. And keep hitting the next. Next. So anyway, sleep got better with IVR. So then he went back to see the child psychiatrist 2 to 3 months later. Next item, please. And the mother was pleased overall. Sleep was better, behavior was also improved. And the doctor was also very pleased. He said, well, she said, it was very good. Well, since his behavior is better, let's just push up the risperidone dose a little bit more. And that way the behavior will see some additional incremental improvement in the behavior. So she increased the dose from 0.5 milligrams twice a day to 1 milligram twice a day of the risperidone. However, 2 weeks later, mother called me, this time called me because of the sleep issue. She said the sleep has once again worsened and he's waking up many, many times at night. So what to do? I said, just drop the dose of risperidol. And she did. And once again, the sleep improved. So I think while risperidone is used quite often in children with autism for behavioral management, remember that it is a dopamine receptor blocker. And if there is too much blocking of the dopamine receptor, restless legs will develop because of relative deficiency of dopamine. So I think one can use risperidone, but I think cautiously and monitor closely for adverse effects such as worsening of restless legs syndrome. Next slide, please. And then there is this obsessive thoughts, and it may overlap with obsessive compulsive disorder, but although one should make a difference, it's not OCD all the time. Next item. And they have perseveration of thoughts. Sometimes a thought gets into their mind and they keep thinking about it over and over again. And in some ways, perseveration is really forgetting to forget, because, we erase from our mind memories that are not needed. When you're driving to work or coming to work, if you saw some cars next to you or whatever, some people, but they're not relevant to you, you forget about those things. But these children, they will just take in stuff into their brain and are not able to eliminate unwanted or unnecessary memories. So they forget to forget and move on. So, and all those thoughts then come into their, conscious thinking process when they try to go to sleep at night. And they contribute to mental activation and insomnia. And just give you an example of a child, the same child I mentioned to you earlier with aggressive behavior and risperidone. Mom took him one day to a go-kart, amusement park where he has these cars, small mini cars which go round and round and round. And he really enjoyed it. This was at 3 p.m. He really had a fun time. But he came back and his mom kept telling him, turn the wheel, Max, turn the wheel, turn the wheel. So he enjoyed the car ride. But he coming home all through the evening, he was just very happy, giggling, turn the wheel, Max, turn the wheel, Max. He was thinking of the car he was driving. He goes to sleep, he's still talking about it. In the middle of his sleep also, she said, he's still talking about turn the wheel, turn the wheel. So these thoughts don't go away from their mind. It's like junk, it just builds up and it causes insomnia. So it's very important that these children with autism have some bland, structured time, but without any exciting activities for at least 2 to 3 hours before bedtime. Whereas we may say in a typically developing child for about an hour, these kids may need 2 to 3 hours of that bland, quiet time to eliminate all those unwanted memories. All right. Then, so we talked about some of these behavioral issues and restless legs and iron. Another one condition is REM sleep without atonia. And of course, for this, you will need a polysomnogram. And in this polysomnogram, the top 2 channels indicate eye movements. I don't know if my cursor is visible or not. And then the next 3 channels are EEG. And then this is chin 1 and chin 2. That's your chin EMG. And below that is the leg EMG activity. And so normally, of course, in REM sleep, there should be no muscle tone, correct? So there should be atonia. But in certain children with autism, there is REM sleep without atonia. In other words, atonia does not develop. So the muscle tone remains active in these children. And why this happens? Because in the pons and the ventrolateral periaqueductal gray matter, there are groups of neurons called REM-on and REM-off neurons. Now, the REM-off neurons are supposed to send projections to the spinal cord, descending projection, which shut off muscle activity. So the REM-off neurons, their function should be to shut off or inhibit muscle activity in REM sleep. But there is some dysfunction here. And those REM-off neurons are not working right. So loss of inhibition, descending inhibition to the spinal cord, and there is presence of muscle activity. Of course, REM sleep without it is a fascinating disorder. You can see it in autism. You can see it in children with narcolepsy. And of course, in elderly, you see it with synucleinopathies, but we don't have that, correlation in children with synucleinopathies. But this can happen. Now, when you see a REM sleep without atonia, it is quite sensitive to clonazepam. It is also sensitive to melatonin. So I think one way to improve sleep in these children, if there is REM sleep without atonia, is to use these two drugs. Another cause for RSWA is use of SSRIs. So they can also activate RSWA. So if you have a patient on fluoxetine, for example, maybe worth considering lowering the dose of this drug. Next slide, please. Yeah. Now, this is a circadian rhythm sleep disorder, and I'm showing you an actigraph for 2 weeks on a child. This is an older child, and he actually cooperated. He was, I think he was about 21 or so. And so 22nd February through 8th March, so about 2 weeks of actigraph data. And these are various days. And the black areas indicate muscle activity, and the clear areas indicate no muscle activity or sleep. So, for example, on the 22nd of February, this is 1800 hours, midnight, 0600 hours, so on. On the 22nd of February, you can see that the patient was awake all the way till about midnight or a little past midnight, then fell asleep, and then perhaps around 10 a.m. or so woke up. And so you can actually, with the actigraph, you can actually document longitudinally for a period of 2 weeks when the person goes to sleep, when they wake up in the home environment. So it's a useful test, and sometimes probably gives us more information than a polysomnogram in children with autism. Now, I had already seen the child, so I had some rough idea what was going on, and I had prescribed a treatment for this child. And you will see that for the first 7 days or so, that treatment is in place. And as a result of which, this is midnight, 1 a.m., 2 a.m. So the child is consistently going to sleep between 1 a.m. and 2 a.m. And then before the child was going to come back, I wanted to see whether the treatment was really effective. So I told the mom, why don't you stop that particular treatment? And then let's him sort of sleep ad lib as he does normally. And notice what happens. Goes to sleep later and later. Here, falling asleep around 4 a.m. I don't know, for some reason here, 1 a.m. Next night, again, around 5 a.m., 6 a.m., 4 a.m. Here, the 8th of March, did not fall asleep at all till about 7 or 8 a.m. So what do you think was the treatment being given for the first week, which was helping maintain fairly regular, still not normal, but regular sleep onset times, which I took away in the second half? It was bright light therapy. So light provided through a light box, which is usually about 6,000 to 7,000 lux. You measure light intensity in units called lux, L-U-X, and it is provided in the first half hour after awakening in the morning. And with the bright light therapy, he was able to maintain fairly consistent sleep onset times. But the moment we took it away, started to drift to later and later times. This is a child with a non-24-hour sleep cycle, which is a type of circadian rhythm sleep disturbance that develops in children with autism. A lot of non-24-hour sleep cycles actually happen in children with blindness. But here's a person who was sighted and had it, and there have been case reports of even sighted, with intact vision, people having this non-24-hour sleep cycle. So this is where use of a bright light box might help. Another strategy might be to use very low dose of melatonin. I mean, if this child is falling asleep around, say, 2 a.m., or perhaps around 6 hours prior to that, around 8 a.m. or so, would be a good time to give a low dose of melatonin, not high, low dose, 0.5 milligrams. And that will also help advance or move backwards the sleep onset time. So bright light therapy early in the morning, immediately in the first hour after awakening, or very low dose melatonin given about 6 hours before bed onset time, 6 hours before sleep onset time, will be helpful in these patients. But you can imagine, I mean, if these children are really sleeping all the way till about 10 a.m. or 11 a.m. in the morning, and they go to school, they're not going to learn anything. If anything, their behavior is going to be disrupted. And with behaviors disrupted, we are going to use medications, maybe even Risperdal to help them. Maybe they're going to have more likely to have seizures, etc. So I think the role of sleep in enhancing enhancing quality of life in these kids is significant. Next slide, please. Thank you. And so how to approach a child with autism in the clinic? I think simple things that we can all do. Take a good sleep history. Events during the day, events during the night, the bedtime scenarios, and I won't go too much into detail, but take a good sleep history. And also keep the family, tell them to keep a sleep diary for about 2 weeks, if they can keep a record of when the child goes into bed, when the lights are turned off, when the child actually falls asleep, how many times he or she awakens at night, what is the time for the final morning awakening, what happens in the daytime, does the child take a nap, if so, how long, etc. And you keep that for about 2 weeks, and that's very helpful. Parents, if you're empowering them, they keep a diary, they feel good about it, that the doctor's really telling them to gather this data. And using the sleep history and sleep diary, you may be able to make out if somebody has inadequate sleep hygiene or behavioral insomnia or restless leg syndrome. Of course, with restless leg syndrome, you will need to check a serum ferritin level. And if you can get a polysomnogram, well, more power to you. That may be helpful. And then, of course, you suspect parasomnia that Dr. Kothari had discussed in the last session last week. You will need polysomnogram with an extended EEG montage, 16 to 18 EEG channels, just to make sure it's not epilepsy, for example. And if is it a medication effect from SSRIs or risperidone, and try to lower the dose or eliminate them. If it's a circadian rhythm sleep-wake disorder, then actigraphy, now I understand it's become difficult to obtain actigraphs these days. So perhaps, data from cell phones or Apple Watch, etc., something like that, maybe value. Bright light therapy early in the morning. It works only if you give it in the first half hour. Melatonin use. So these are some approaches. Next slide, please. Another approach, if you want to look at diagnostic approaches, you try to see if they have trouble with based on the sleep diary, there is irregularity in sleep onset. In other words, one day they fall asleep at 9 p.m., next day not till 11:30 p.m. And also morning wake-up times are fluctuating all over. Think about environmental factors, think about behavioral insomnia, anxiety, depression, circadian rhythm sleep disorders, and medication side effects. Next. On the other hand, their bedtime is fairly stable. They don't have any major difficulty falling asleep, but they just wake up many, many times at night. Then you got to think about parasomnias of REM or non-REM sleep. You got to think about, keep hitting the next button, epilepsy, nocturnal seizures, RLS, OSA, gastroesophageal reflux, and medication side effects. With RLS, what you're looking for really is increased frequency of periodic limb movements in sleep. And normally the PLMs are about 5 per hour of sleep or less, but they may be more in these patients. Just a few comments about treatment with melatonin. This is a paper from Olivier Brunei, published in the European Journal of Pediatric Neurology in 2015, and they had gathered a series of experts. In Rome in 2014, and they found of all the various drugs that people use to improve sleep in children with in children with autism, melatonin was the best in terms of improving sleep onset insomnia and also for delayed sleep phase syndrome. Next. And for delayed sleep phase syndrome, that means they go to sleep progressively later and later times at night. It is best when it is administered 3 to 5 hours before dim light melatonin onset. This is very hard to assess dim light melatonin onset unless you have actigraphs or sleep diaries, but usually you can, gather it indirectly from the history. What melatonin seems to do is decrease sleep latency. In other words, it takes less time from lights out to falling asleep, and also seems to increase total sleep time, but does not change the frequency of night awakenings. Next. And so I'm on this International Pediatric Sleep Association as a board member, and 2 years ago, the IPSA developed a task force to evaluate evidence for the use of melatonin, how effective it is. And we had to look at subjects who had sleep initiation or maintenance difficulty in relation to autism. Next slide, please. Yeah. Next. And we included patients after 2012, and we looked at studies which had a randomized placebo-controlled design. Next. Next. So there were 8 studies, not very many. And 6 of the 8 were RCTs, where 2 of the 8 were open label design. We pooled all the subjects, total 1671 subjects. They were between 2 years and 17 years, and 2/3 were male. The dose of melatonin used was kind of all over, 2.5 milligrams to 12 milligrams. And each publication was reviewed by 2 experts, sleep experts from all over the world. And then we look at the outcome variables, and they were really very diverse. And there were questionnaires in all 8 studies, sleep diaries in all 8 studies. But actigraphy was available only in 5 studies. Pittsburgh Sleep Quality Index was used to assess sleep in the parent in 3 out of the 8 studies. World Health Organization Wellbeing Index to assess parents, 3 out of 8. Child Sleep Disturbance Inventory in 2 out of 8. Strength and Difficulties Questionnaire for Child in 1 out of 8. So really the measures used to assess sleep in the child or the parent were really very diverse, and they're from all over the place. Next. Next, thank you. And then the type of melatonin, there is a pediatric prolonged release melatonin, which was available in Europe. And that works really all through the night. And it's actually excellent. And if you can get it, that's the type to use. Because the regular melatonin has a half-life only about 45 to 60 minutes. So pediatric prolonged release melatonin is the way to go. And that was used in 4 studies, fast release or immediate release in 3 studies, and control release, which is slightly different from PRM, was used in 1 study. Next slide, please. And the results, the maximum duration was 12 to 52 weeks for the RCT phase. Next. In 4 out of the 8 where actigraphy was used, sleep onset latency was reduced. In other words, they were falling asleep faster by about 40 minutes over placebo. Next slide, please. And where actigraphy was used, total sleep time also increased significantly over placebo. Next. And in 1 particular study, they looked at behavior. They found that with the melatonin, there was an improvement in the daytime behavior as well. Next. And the side effects were sort of minimal: fatigue in 6 to 18%, somnolence in 6 to 28%, and cough in 1 study at 13%. Next, please. Caveats: there were no studies below the age of 2, and I would really caution using melatonin below the age of 2. There have been some possible 2 cases of death in association with melatonin use in those below the age of 2. So till we know better, I would avoid it in kids below the age of 2. In the study with the longest follow-up of 100, so Beth Malo's study, so 52 weeks, it was a RCT, placebo control, but after 52 weeks, it kind of broke the code, and they continued the open label till 103 weeks, or almost 2 years. And there's always a concern: will melatonin affect sexual development or body weight or body mass index? And in this particular study, where they carefully evaluated the Tanner stage of sexual development, they did not notice any difference from typically developing children controls. Next slide, please. There was a possibility of observer bias in sleep diaries, but there was maybe use of actigraphs in some studies, so that may have helped. Next. And the dose was between 2 to 12 milligrams. And I think at this point, the dose is recommend is upper limit is 10 milligrams, but lowest dose 1 to 2 milligrams, and then reevaluate periodically every 2 to 3 months is kind of the way to go. Next. The study did not compare prolonged release or immediate release. And they felt that if you're going to use melatonin, combining with behavioral intervention may be better approach. But this is, once again, it's a soft sort of recommendation. Next. No data on which specific sleep problem, like delayed sleep phase syndrome or multiple night awakenings, would benefit from which type of formulation or what dose. Next. All right, there's a couple of slides from Autism Speaks, which is a wonderful resource for parents, and it's online. You can look at it wherever you are, but I think it's helpful to involve parents in this discussion. But the main concept they talk about is for the child, providing a comfortable sleep environment, establishing a regular bedtime routine, teaching the child to fall asleep alone. So that means a parent, after a good night kiss or a hug, leaves the room before the child actually falls asleep. This will encourage the child to ultimately develop some self-confidence in being able to fall asleep on her own or his own. And promote healthy daytime behaviors. That includes physical activity and just minimizing daytime naps. Next. And visual schedule that Autism Speaks has recommended, I think is very useful, and you can adapt it to your own, cultural needs. And but I think here they talk about putting on pajamas and using toilet, wash hands, brush teeth, etc. And children really love to have this on their bedroom door and look at it and just put an X that, yes, I've done this. Then I go to use toilet. Yes, I've done this. So children with autism love to keep lists and schedules. So, this type of organization really helps them. And in other words, look at the bottom, drink water, read story. They read the story, then they know, oh, okay, what's the next thing? I need to go to bed and I need to sleep. So I think that it really helps them understand the sequence of events that need to happen in the 1 or 2 hours before bedtime. And it really helps them that way. Next. Okay, we'll come to Q&A in a moment. And I think we can move past this slide. It's probably not in the interest of time. We can just advance the whole slide. Yeah. Just to think about melatonin in the slow wave sleep. This is a RCT of prolonged release melatonin with temazepam, which is a hypnotic, and zolpidem, which is another hypnotic, on slow wave activity in healthy people. And if you just look at the top, there are 4 cartoons, but if you would just please look at the top one, the black bar indicates prolonged release melatonin. This is EEG power, delta power, and the gray one in the middle is temazepam, and the white bar on the right is zolpidem. It appears that there is a significant increase in the slow wave activity with melatonin as compared to temazepam or zolpidem. So it boosts slow waves sleep activity. That's activity in the 0.75 to 4.5 hertz range. Next slide. Well, why is slow wave activity important? Well, we look at the evidence from the lymphatics through which waste matter is eliminated from the central nervous system. And if you look at the top of this cartoon, which says young, and the channel on the right here, light blue, You can see it has two types of colored rods, and they only look like bacilli. The pink rods are the metabolic waste, like lipids and amino acids. The yellow bars, you can see them, I'm sorry, they're not very clear. Those are the beta amyloid areas. You can see that there is fairly robust during slow wave activity in young people. There is fairly robust clearance of metabolic waste and beta amyloid from the brain. In the old people, healthy old, not much. In the Alzheimer's, even much less. Just hit the next slide. Next button. Slow wave sleep facilitates transport of beta amyloid from the brain. And of course, slow wave sleep is essential for consolidation of memory and synaptic plasticity. In general, that's why we need to consider melatonin, because it has a favorable impact on slow wave activity and indirectly might help with the memory. Next, please. And yeah, we can, just shows more of the same, that melatonin modulates daytime dependent synaptic plasticity. Next slide. In summary, therefore, sleep initiation and maintenance difficulties are very common in children with autism. They're generally multifactorial. Next. And they may be associated with daytime neurobehavioral disturbances, worsening of epilepsy, increased utilization of healthcare resources, and increased caretaker stress. We didn't talk too much about it today, but it is a significant issue. And detailed sleep history and sleep diaries are useful starting points in the assessment. Next. There's often a need to providing emotional support to the family. Pharmacological therapy may consist of melatonin. In some cases, people use trazodone, but be careful if somebody has seizures. Monitor for iatrogenic precipitants. And behavioral therapy provided concurrently with pharmacological therapy may lead to better outcomes. The long-term impact of insomnia, however, in terms of outcome in autism, has not been evaluated. And I will stop here, open for questions, Q&A. Yeah.
Thank you very much, Dr. Kotkal, for a very, very elaborate talk. And of course, touching so sensitive issue,
Yes.
sleep in autism. Also, we know you touched the point that it does not affect quality of life for child, but also for the whole family.
Yes.
We know if you have 2 hours of night disturbance because of emergency, next day is ruined. And these
sure.
families are having sleepless nights for months and months.
Yeah.
And of course, you covered so many important basics, evidence, and important clinical hints and aspects. I think it has quite a few questions, but before we take the questions, may I please request our experts, Dr. Kothare, Prof. Karna Madam, and Dr. Piju for your comments, please.
Hi, so Suresh, as usual, beautifully done. Covered almost all the aspects that I just want to add 2 additional points. One of the thing is that in our experience, and we have published a paper, and Dr. Gulati has those articles. I just emailed it. I just sent it on the WhatsApp. We published a paper looking at how do you treat the insomnia in autism. We have a huge autism population, and we have published a paper looking at doxepin. Now, doxepin is an older antidepressant, anti-anxiety drug. The doses used in psychiatry are like 75 and 100 milligrams. And they act on the serotonin and norepinephrine and dopamine pathways.
Yes.
But when you use a very low dose of 10 milligrams, that can increase that can actually become very sedative And we have found that 10 milligrams of doxepin along with melatonin is very useful in children with autism. Especially it takes care of the sleep maintenance insomnia. Sleep onset insomnia is addressed through melatonin, but sleep maintenance insomnia is better addressed through doxepin. In the adult world, this is available as a 6 milligram brand name called Silenor. In children, we use liquid, 10 milligram per ml, and there are 10 milligram capsules available. I'm sure that doxepin is available in India also, and it's a great drug, very safe. The article that I have sent to Dr. Gulati, she'll be happy to share it with the group. That's a great drug to use when
Sharing. I'm just sharing.
Yeah,
and
thank
so
you.
that's one thing. Secondly, as these autistic children become adults, it is very important to have guardianship issues addressed so that parents, at least in the US, if the guardianship issues are not addressed, these kids are state wards and parents have no control over them. And they have no control over their medical care. So guardianship should be established between 18 and 21. And then vocational guidance and rehab should be addressed with them. So there's an article that we have published on that, and she's going to share that next, where transition of care should be done in a very systematic and scientific way. I must say that some of these autistic children are high functioning, and their skills are used in the daytime for other purposes. The Israeli government actually use these high functioning autistic teenagers and adults, young adults, to look at their surveillance programs for military attacks because they have such good observations that when they're given this task with computer skills and all those things, that they do very, very well on that. So vocational guidance and placements are very important for them. And then finally, of course, he has addressed this issue, but we looked at systematically ferritin in patients with autism, and they are low. And why they're low, I'm not clear, but they do respond to iron with both the PLMs and RLS going on board.
Yeah.
Finally, I want to add that 1/3 of patients with autism also have epilepsy. So when they have disturbed sleep patterns at night, I usually get an EEG added because there's a condition called ESES, electrical status epilepticus of sleep, which is seen quite commonly in autistic population. And in them, we need to address the ESES. So using a benzodiazepine or steroids may be useful to take the spikes away and improve their sleep and their overall cognition. So
Yeah.
1/3 of patients with autism have epilepsy also. So those
Sure,
are my
no doubt.
comments.
Yeah, in the interest of time, I didn't really want to cover too much of those, but your points are well taken. Then, particularly with the doxepin, I think it's a useful drug, and I'm glad you published that data because I think it's quite an effective drug. I agree. Thank you.
Yeah. When we published, the other thing I want to caution people is that don't, so, you start at 6 milligrams, they're doing good, and then they have a breakthrough at 3 months later. So you go up to 10, then they have more breakthroughs and you feel, hey, let's go up to 15, let's go to 20. Don't do that. As you go on higher doses, the dopamine and norepinephrine kicks in and you get insomnia actually. So stay put at 10 milligrams.
And the other thing is, whenever you use pharmacotherapy in these kids, there's always some sort of a behavioral insomnia component. So don't forget that part. That also needs to be addressed because, it's never pure behavioral insomnia. It's never pure organic. It's often a combination of two. And even if they're getting doxepin or any pharmacological therapy, they might still benefit from some sort of hand-holding and behavioral therapy. The child as well as the parents. Good points. Thank you.
Pitch in? Can I pitch an excellent talk and excellent discussion? Going on, just wanted to add on to the ESCS, wanted to clarify for attendees that, when you are suspecting this, you have to have a sleep and awake both EEG. And awake EEG may be actually normal at times. So that just has to be kept in mind because we are seeing it quite frequently and that is something important. Yeah. Dr. Kalra, Professor Kalra, ma'am. Dr. B.
Hello.
Yes, ma'am, you're audible.
Okay. So,
You're visible too.
so it was really a most exhaustive, detailed, in-depth talk about how to manage and also about neuromechanisms. Believe me, it was honestly a very, very enlightening talk. Really enjoyed it. And I wish to
Thank you.
thank Dr. Kotigal and Sanjeev for a wonderful discussion. And I think we've all benefited from your wisdom and expertise, Suresh.
Thank you so much. Thank you.
Thanks a lot.
Pleasure. Thank you.
Thank you, ma'am. We have Dr. Biju to talk, then we have two cases also. Dr. Biju?
Thank you. Thanks, Professor Kotigal. Fantastic talk as always. I know last year you've given an excellent talk for the ICNTN
Oh, yes.
as well. I would want I wanted to echo your points, like, because I always think like, so what, when it comes to sleep, what makes the autism children different to perhaps other children with other neurodevelopmental disorders? And I think your point about behavioral therapies taking priority over pharmacotherapeutics, I think that's a very important point, a take-home message from your talk. Particularly,
Yes.
it also depends on the culture. Like the place where I am practicing now, culturally, there are still lots of children co-sleeping with parents, either with parents or co-sleeping with the
Yes.
maid or nanny. And often when we try behavioral techniques, often it's very hugely beneficial to have behavior training for the parents.
Very true.
Rather than
Yes.
for the child. It often
Yes.
often works very
Yeah,
well.
yeah.
The other little point which I wanted to ask you was, I know some colleagues who look at cortisol levels, particularly in the children with autism, because of the early morning awakening being a major problem at times, because the parents are still sleeping, but the child is up and running like
Yes.
3 in the morning.
Yeah.
What's your thought on those looking at the cortisol levels?
I think that's a fascinating thing. I was not aware of that, but I think it makes sense, provided one is able to correlate it with the state of the child. Is the child asleep or awake? I think it would probably correlating with the actigraphy. That might be of some value. I had not, thought about that, but I think that's a very nice way to approach sleep-wake function in these children. What is your feeling about that? Does it you think it's a good approach?
We don't routinely do, but when you look at the mechanics of it, seems to be some logic in it. But I don't think any of us really do that. Like I know, like same way, like people look at sleep spindles and correlate the number of sleep spindles with the IQ, for example.
I think it's it's not practical in the field, I guess. That's very true. But your point about behavioral insomnia, I agree. The only problem with, you have to be careful when you discuss about behavioral insomnia, parents, we have to make sure they understand they're not bad parents. We're not blaming them. It's just the situation is such that we have to suggest that. Sanjeev, what are your thoughts about this early morning cortisol?
I mean, I think it's a research question that needs to be addressed in a research manner as to how we can modify treatment based on that.
Yeah.
Can we modify any form of treatment based on what data you're going to get from that? Or is it just a scientific observation which doesn't have practical implications? Yeah,
no, that's a good point. Okay, thank you. I think let's go to the Q&A.
I already answered you one of the question about the melatonin, the chronohypnotic, the chronobiotic doses. I've already put that in the text, so that helps you.
Yes.
Okay,
also,
thank you.
Since Dr. Gulati mentioned about the ESAs, I've just sent two other articles to the crowd about ESAs and the treatment for ESAs.
All right. So now at the bottom, there's one which says chat and number 8, and then Q&A 5. So which one should I should get?
Dr. Nitish can read out the questions. Dr. Nitish can read out. Nitish can read out fast. Yeah. Nitish can do that.
Sure. Does cell phone, this is Dr. Akhauri Yash Sinha, does cell phone wave or Wi-Fi wave affect sleep of autistic children in any literature evidence? I can't quote you a paper, but yes, there is a correlation in typical or healthy children that use of cell phone is going to inhibit melatonin because the light emitted is significant. So that by itself is going to inhibit melatonin prior to bedtime and interfere with sleep onset. That, of course, the content of what one is reading on the cell phone, that can also be mentally stimulating, maybe upsetting, or maybe something happy. But either way, in children with autism, once that gets into their brain, they're not going to be able to eliminate it as easily. So it certainly could contribute it. So when we talk about sleep hygiene in these kids, for the 2 to 3 hours before bedtime, that's why they should not be using any electronic devices, and it includes TV. What is the ideal dose of melatonin for autism? Sanjeev, you mentioned you already answered that question, correct?
Yes.
Oh, all right. Then we go to Dr. Gauri Rao Pasi. Is there any role of weighted blankets for autistic children with sleep issues? So there was a practice parameter put out by the American Academy of Neurology, where they found that it was not of any significant value, the weighted blankets. And others may feel differently about it. I think the trouble with weighted blanket is you don't really know how much weight and whether that weight is actually going to put so much pressure that actually increase awakenings. In the study, you showed us ASMT levels were lower in the mothers. Well, it may be that it's a genetically determined trait, and maybe that's the reason for it. But let's go back to the weighted blankets issues. Anyone have other thoughts about it?
Suresh, I have heard many
in the
families telling me it does
in the
work.
UK,
Yeah, I'm sorry.
Yeah,
It
no,
does
I think
work.
that's the whole thing about it. Yeah.
No, Suresh, in the UK, we often rely on the sleep charity called Cerebra. And they have a bunch of sleep practitioners who gives advice to parents, and they think very high of this the sleep weighted blankets.
Okay.
And they provide
So
free blankets, free weighted
that's
blankets.
the whole thing. I think
families.
I think uncontrolled observations, yes, but the AAN parameter clearly stated that there was no difference. So maybe they were looking at it more critically. But I think in practice, maybe it's okay to use. Maybe this is something we should really investigate further and maybe have a discussion later on about weighted blankets, but and we can pull out the AN paper and talk about.
I think, Suresh, the way these consensus statements are based, they are based on double-blind placebo-controlled studies. There is nothing like that available, so it's more anecdotal.
Well, that's the whole thing. So the point in literature is, on what type of evidence are you going to change your method of practice? In general, changes in the method of practice should be based on level 1 or level 2 studies. Anything below that is, becomes a little empirical, if I may say so. So that's the whole issue about it. And but I'm open to. I mean, if you guys are thinking it's helping, fine, try it. And, there's always a difference between a practice parameter, as you say, and actual clinical practice. So, yeah. Iron, role of iron, histidine, I'm not sure. I don't know that particular preparation. Maybe whoever asked me the question could elaborate on it. Dr. Deepak Dwivedi. Okay. All right. Well, I don't know. And then we have Dr. Mohsin Ali. Any side effects of melatonin observed? The data were mainly about somnolence. So sometimes it can be fairly longer acting. So even though you take it around bedtime, it may still be present in the early morning hours. So I think the somnolence was noted in about 16% of the IPSA paper that was published in Sleep Medicine in July. And then the other one was vomiting, and those were the two major ones. Yeah. Oh yeah, headache is another one. I don't know why that happens, but it has been noted in patients.
Yeah.
Thanks, Dr. Kotal. So we have one question from our the panelist, Dr. Bishwarup.
Yes.
He can speak himself. He
Yes,
can himself say, no? You can ask yourself. Yeah.
Yeah, thank
Hi,
you, ma'am.
Dr. Bishwarup. Yes.
Yeah, hello, sir. Hello, sir. Good afternoon, sir. So the question is, can we have REM without atonia on MSLT narcolepsy patients?
Good question. Yes, you can. I mean, if you have REM sleep, and if it's fairly robust, the thing is, it's not always. I mean, if somebody is in REM for, at say at nighttime for 20-25 minutes, there's a greater chance you will capture it. On the other hand, on the daytime MSLT, the REM sleep may be present for maybe a shorter period of time, 2 or 3 minutes. So, but you can see it. There's no reason for it to not be there, but you can certainly look for it. Yeah.
I've seen it. I've seen it.
Yeah. When you look for
Actually-
REM sleep without atonia, just be careful not to look at that it's not preceded by a respiratory event, because sometimes EMG gets activated because of some mild sleep apnea, or there is no other leg movement. But if it's just pure atonia, with REM sleep without atonia, you should be able to pick it up.
And I think, just to clarify for the audience, REM sleep without atonia on a polysomnography is defined as if you take a 30-second episode, 50% of that 30-second episode, which is 15 seconds, has increased chin or leg tone. So that's how it's defined as that.
Correct. And the way to look at compare it is go to a period where there's non-REM sleep and look at the chin EMG data there, so you can compare the two. Yeah.
So a question, Dr. Kotal, and which anyone can help. Anything can help with the intermittent wakening. So children who have intermittent wakening during the sleep, what medication can help? And second is any role of clonidine with sleep issues.
Oh, yes. So we'll take clonidine first. Anxiety is a significant comorbid factor in children with autism. And clonidine, by virtue of its anxiolytic effect, is beneficial in a low dose. And it certainly can be of some benefit if there's a lot of anxiety.
Sure,
then
sir.
The other issue, the intermittent night awakenings, you want to make sure that it's not due to restless leg syndrome. So check a ferritin. You want to make sure it's not due to obstructive sleep apnea. So ask about snoring and check oximetry if you have to, or if you can get a PSG polysomnogram, certainly look for that. So, or acid reflux. So I think all of those factors should be looked at. And if there is no other underlying pathology, then I like Dr. Kotari's idea of doxepin. I think that would be a good thing to try. Clonidine might be of help. And if you're in UK, I suppose you can get the pediatric prolonged release melatonin. That would be excellent. I don't know what's happened because of the war. The company that makes pediatric prolonged release melatonin is called Neurim. They're from Israel, but when I talk to them, in Glasgow.
But
few
sir,
months
I'll
ago.
tell you, no, but I'll tell you which has been released, sir. It's being launched in India.
Awesome.
So it will be coming soon in the market in about a month's time. That's what I was
Yes.
told. So
Very
it will be
nice.
coming within a month. It will be in the market. So we'll have a sustained release melatonin in India.
Oh,
They've already
nice.
started it, but the market it will be within a month's time. Yeah, yeah. One thing I'll have to in right now is we are only 1 minute behind and 1 minute from the session, but we had 2 cases. I will request you, if you permit, to prolong the session by 15 minutes
Oh, surely,
so that
surely.
we give them about 5
Yeah.
minutes for the cases, because and you have one question. By the time you can answer that one question.
Okay.
Uh,
Yeah, there's one question I
one
can
question,
answer now.
Nitish.
Anonymous attendee, should melatonin be
Yeah, sure.
tapered or can be abruptly stopped? You can stop it abruptly. It's, doesn't seem to have any negative consequences.
I also want to add a word of caution with clonidine. So clonidine's half-life is
Yes.
2 to 4
Yes.
hours maximum.
Don't stop that.
So
Yeah.
invariably what happens with clonidine is you give it in the night at 10 o'clock, at 2 o'clock it's gone. When clonidine goes out of the system, you get REM rebound. And these
Right,
kids wake up with a nightmare. So I prefer guanfacine, which is a little longer, or clonidine extended release. Those are better options rather than plain clonidine.
Very helpful, sir.
Good point.
Thank you.
Thank you.
Yeah, one more question. Rajita has written, what is the role of lemborexant?
Not that we know about. It probably
Okay.
is of some benefit. Yes.
Yeah. Okay.
It's not approved.
Nitish, can you?
Not
Yes,
It's
approved.
not approved for children.
Shall
Yeah,
we for
thanks.
Dipti then?
Thanks. Nitish, call the first
Yes,
case.
sir.
And please, I'm
Dipti?
requesting, can you keep it 5 minutes? Yeah, please keep 5 minutes because we don't want to cancel cases, please.
Definitely.
It's very nice to encourage the early career researchers to present cases. So 5 minutes each.
Sure.
We anyway have told you 5 minutes. We're not reducing the time anyway. So 5 minutes was already told. So yeah, 5 minutes plus 2.5
Dipti,
minutes
you want to share the
discussion.
slides, please?
Who's the first
Dipti?
one?
Dipti from AIMS Delhi.
Dipti?
Yes, sir, I have shared.
Dipti Krishna, yeah.
So are my slides visible?
Yes,
Yes.
yes.
Full screen karo.
Good evening, everyone. At the outset, I would like to thank AOCM for giving me this opportunity. Today, I'm going to discuss 3 cases from our study, correlation of sleep architecture with cognition, behavior, and executive function in children with pharmacoresponsive non-lesional epilepsy. In our study, we included children aged between 5 to 18 years who were labeled as pharmacoresponsive non-lesional epilepsy and were seizure-free for more than 12 months. And we assessed the following parameters. For sleep, we used childhood and adolescent sleep evaluation questionnaire and polysomnography. For behavior, we used childhood behavioral checklist. And for cognitive and executive functions, we used Stroop test and WISC-4. The childhood, adolescent, and sleep evaluation questionnaire was developed in our institute, and this is a screening instrument which was based on ICST-3 guidelines. Coming to case 1. Case 1 is a 13-year-old male child who is a known case of primary generalized epilepsy who remained seizure-free for more than 1 year on valproate. On assessment, the child had impaired social performance. There was a history of behavioral problems in the form of irritability. The child had snoring while sleeping. The child had excessive movements of the limbs while sleeping. On evaluation on polysomnography, the child had elevated apnea-hypopnea index and also elevated periodic limb movement index. On further evaluation, at the baseline, the child had full-scale IQ of 119. On CBCL, the child had a clinically significant T-scores in the anxious depressed domain. On further evaluation, the child fulfilled the criteria for anxiety disorder as per DSM-5. However, the Stroop test was normal. Hence, a final diagnosis of primary generalized epilepsy with sleep-related breathing disorder, sleep-related movement disorder, and anxiety was made. Apart from anti-seizure medication, sleep hygiene was emphasized. As the serum ferritin was low, oral iron supplementation was given, and for anxiety, cognitive behavioral therapy was advised. 6 months post-intervention, the child was again reassessed, and at this time, the child had improvement in full-scale IQ, and the symptoms of anxiety was also reduced. We also assessed quality of life using Pete's QL inventory scale. At the baseline, the child had significant impairment in the emotional functioning. However, after 6 months of intervention, the child had improvement in emotional functioning scales. Coming to case 2, he is a 12-year-old male child who is a known case of self-limited focal epilepsy. On evaluation, the child was noted to have lack of attention and concentration. There was behavioral problems in the form of hyperactivity. The child used to have brief episodes of nocturnal awakenings and sleep talking. The child had history of excessive movements during sleep. On polysomnography, showed elevated apnea-hypopnea index, and periodic limb movement index was also elevated. On further evaluation, the child had full-scale IQ of 114. On CBCL, the child had clinically significant scores on attention domain. However, the Stroop test was normal. Hence, a final diagnosis of self-limited focal epilepsy associated with sleep-related movement disorders, sleep-related breathing disorders, parasomnias, and ADHD, predominantly inattentive type, was made. And apart from anti-seizure medication, sleep hygiene was emphasized. Oral iron supplementation was given for symptoms of SRMD, and for ADHD, child was started on methylphenidate along with behavioral intervention. After 6 months of therapy, the child was again re-evaluated. At this time, the child had a 5-point improvement in the full-scale IQ, and also there was improvement in ADHD symptoms. Coming to the quality of life, at the onset, at the baseline, the child had significant impairment in social functioning, which showed improvement 6 months post intervention. Coming to case 3, she was a 12-year-old female child who is a known case of self-limited epilepsy with centrotemporal spikes. On evaluation, the child had lack of attention and concentration, and there was behavioral problems in the form of hyperactivity. The child used to sleep off and get up later than the conventional bedtime. That is, the child used to sleep after 12 a.m. And there was also history of excessive movements of the limbs during sleep. On evaluation, on polysomnography, the child had elevated periodic limb movement index. On further evaluation, the full-scale IQ at the baseline was 88, and on CBCL, the child had clinically significant scores in the attention problem. Connor's parents' report also showed clinically significant P scores in attention problem and hyperactivity. The child satisfied criteria for ADHD as per DSM-5. On Stroop test, the child was found to have word score of 38 and color score of 40. As the word score was less than color score, the possibility of specific learning disability was also kept and was further evaluated. Hence, a final diagnosis of self-limited epilepsy with centrotemporal spike, sleep-related movement disorder, circadian rhythm sleep-wake disorders, ADHD combined type, and specific learning disability was made. Apart from anti-seizure medication, sleep hygiene was emphasized, and oral iron supplementation was given, and melatonin was given for circadian rhythm sleep-wake disorder. Methylphenidate and behavioral intervention was advised for ADHD, and remedial education was advised for specific learning disability. Post 6 months follow-up, the child showed improvement in full-scale IQ and also improvement in ADHD symptoms. The child also showed improvement in the emotional functioning and school functioning post 6 months follow-up. As we already know, there are studies which have shown that the so-called benign epilepsies or self-limited epilepsy also affects cognition and behavior. In a study which was done in our institute, 50 patients with well-controlled epilepsy were enrolled, and in those children, WISC-4 and CBCL scores were significantly impaired in children with epilepsy when compared to controls. This is a cross-sectional study which included 46 newly diagnosed self-limited focal epilepsies. In this, the children with epilepsy had a shorter total sleep time, prolonged sleep latency, increased wake after sleep onset, and increased sleep fragmentation. And these children also exhibited impairments in cognitive domains and higher rates of internalizing and externalizing problems, social issues, attention deficit hyperactivity disorder, depression, and anxiety compared to adults. The take-home message is the impact of self-limited epilepsies on academic performance and executive functions is underestimated. As we already know, epilepsy and sleep are interrelated. In children with epilepsy, the disturbed sleep architecture may further contribute to cognitive impairment and behavioral problems. Early identification and targeted interventions addressing these sleep issues could potentially improve overall outcomes and quality of life. Thank you.
Thank you, Dr. Dipti. Dr. Abhishwar, do you have any comments or suggestions on this?
Yeah. The basic idea is, these 3 cases were presented, which are part of an ongoing DM thesis. And our basic idea was to highlight the fact that when we look at self-limiting focal epilepsies and idiopathic generalized epilepsies, in which the patients are seizure-free for more than 12 months, our tendency is usually to just visit when they come for our visit to see that there are no seizures, repeat the anti-seizure medications and send them home. But when we delve deep into their other problems, we saw that there are things which may be in the normal range, but if intervened appropriately, they can improve further. So what we saw in this study, because we were doing it as a part of a study, so when we looked at sleep comorbidities, and because of identifying sleep comorbidities, we went ahead and then we did the behavioral identification and cognition identification, and we intervened for sleep as well as behavioral comorbidities. We saw that the cognition also improved, the behavior definitely showed improvement, and also we could see some improvement in the quality of life. So the basic idea is, when we look at so-called benign diseases as well, if we identify sleep and other comorbidities and intervene, we may actually see improvement. But these were just 3 cases which are part of 50 cases being evaluated. So the definitive conclusion can only be drawn when we see them in large numbers. And apart from this, our center, we have been doing studies on autism. One has already been published where we looked at the prevalence of sleep disorders in autism, in which PhD was done in all of them. And also an intervention module is being currently evaluated in children with autism for sleep disorders. Shefali ma'am, your inputs on this, ma'am.
Dr. Shefali?
Shefali ma'am, are you around?
Was just some signal issues. That's what.
Yeah. So.
Well, if I may chime in, because sorry, I have to leave. I have a medical appointment, but these are excellent presentations. Hats off to you for the quality of the data. The questionnaire data pre and post that you have gathered. I think Dr. Tejaswani, a nice presentation. My question is, for the adenoid hypertrophy, I know you're using steroid spray, but on follow-up, if there is residual or persistent adenoid enlargement, do you consider surgical approach?
Dipti, you can answer the question. Dipti, are you around?
Sir, on 6 months follow-up, the child showed improvement, like decrease in apnea-hypopnea index, sir. Most of the patients have shown response to metaspray.
Okay, so there was no need to.
Sir, I'll take your question. So what we usually do is, when, as she said, that this was part of a study and it was done in 6 months follow, but usually at 3 to 6 months, the ENT person sees the child again. And if there is no symptomatic improvement on steroid spray, or if the AHI has worsened or not improved further, so they usually don't intervene. Otherwise, we do go ahead with adenoidectomy. The only thing is, usually the ones which are mild with AHI of less than 5, they're usually, the threshold for adenoidectomy is slightly low. But when the AHI is higher, more than 5 or more than 10, the threshold is higher, sir, in that cases.
Good. This issue of this, thank you. This benign word has caused us so much difficulty. You look at benign familial neonatal seizures, benign Rolandic epilepsy. This word benign has gotten into the literature. Obviously, it is from 20, 30, 40 years ago. And as a result of which, I think a lot of child neurologists have said, dismissing, oh, okay, this is a benign condition. Let's not worry about it. But, it sort of masks underlying other neurological problems or comorbidities. And I'm glad you guys are doing a systematic approach on this.
Thanks, Dr. Kodigal. I think in last
I just want to add
yes,
1 second. I said I say the problem with catastrophic on the other side. Those terminologies both are not being preferred now, both benign and catastrophic, because it becomes this thing.
Exactly.
So actually, I was this work which Yeah, and this autism, we had done, on 100 patients earlier, and in that, we had found on 3/4 of them, 77.5% had positive on a CSHQ score. Although SQ has one problem. If the child is sleeping with the parent, is taken as abnormal. And in India, most of them, like Dr. Biju was saying, he's in the UAE currently, but India, most of the children still with parents. And right now, keeping in mind what you said, that you have to have a comprehensive thing. You have to tell the sleep hygiene and all the things, plus a behavior intervention. That is what we're doing in this current dissertation in autism spectrum disorders. Yeah, thank you, Nitish. The next case. Yeah, next.
Yes.
Sorry, I'm going to have to leave. I have a appointment to go to. Thank you for the opportunity. And
thank you. You want to give a take-home message, Dr. Kotakal? Take-home message as mandatory.
Well, just make sure you evaluate, get a good sleep history, sleep diaries, and listen to the parents of what they're saying. A lot of times you may be able to manage without the sophisticated sleep studies, and make sure you have a team approach and continue to provide some support, emotional support to the families.
Yeah, and one request that I would request you and Dr. Kothari, maybe sometime in November, we may just have talking about how we can actually do practically, and whether actigraphy, where it fits, we may have a debate or discussion kind of thing, rather than, something, because actigraphy is now come up to us now. So how much we can use actigraphy, and especially with these children, it's difficult to keep them, overnight, how much actigraphy can help and their protocols. Yeah. Thank you so much, sir. Thank you so much.
Thank you very much.
Thank you. Dr. Sanjeev, you'll stay for 5 more minutes?
Yeah, of course.
Yeah, thanks. Thank you so much.
Thanks,
Dr. Biju, 5 minutes more?
Yeah, sure.
Yeah, thanks. Yeah.
Dr. Amresh, would you like to go ahead with your case, please?
Yes, sir, my screen is visible?
Yeah. Yes, it's visible and you're loud, clear.
Yes, sir. Sir, good evening.
You are not visible. It's okay.
Hello. Yeah, the title.
Continue.
Yes, sir. Ma'am. Today, my case is a rare case of drug-resistant epilepsy with hypersomnia, with developmental delay, with autistic features. So I am Dr. Amaresh. I'm pediatric neurology fellow from Indira Gandhi Institute of Child Health, Bangalore. My moderator is Professor Dr. Baikuntha Raju. He's a HOD and of the Department of Pediatric Neurology, Indira Gandhi. So this was a 4-year-old male child hailing from Karnataka. The informant was mother, presented with a complaint of global developmental delay since birth, with seizures since 1 year of age, with increased sleep span. So the birth history: the child was born full-term by non-vaginal delivery with birth of 2.5 kg. There is a history of mechanism staining of the LICAR was present, and the child required bag mask ventilation for 4 minutes. With the Apgar score at 1 minute was 3/10, and at 5 minutes it was 4/10. Such a moderate penile asphyxia. Sepsis skin was negative. The child was discharged from after 3 days with the proper establishment of the external breastfeeding. The child had a developmental delay since birth, predominantly involving the cognitive milestone compared to motor milestone, with autistic features. The child had baseline developmental delay since birth. The child had 1 episode of fever-triggered seizure in the form of GTCS type of seizure at 1 year of age. After that, the child started to have recurrent episodes of seizure, which were refractory to anti-seizure medication. We tried vigabatrin, we tried clobazam, we tried phenobarbital also, but there was no improvement in the seizure burden. So the child gradually developed autistic features in the form of restrictive behavior, stereotypy, self-talking, decreased word output. The child had increased sleep span with the daytime dozing, with poor attention in the daily activities. The child also had involuntary round, repetitive, low amplitude, slow writhing movement of the hands, suggestive athetosis involving the hands and the tongue also. And the child also had some ataxia in the form of clumsiness while walking. There is no history of any diurnal variation of the symptoms or episodic fluctuation of these clinical symptoms. There is no history of any acute encephalopathy. There is no history of any autonomic symptoms or aggressive behavior or self-mutilating behavior. And there is also no history of any polydipsia, polyuria, or excessive weight gain. So there is no family history of any similar illness or abortion or sibling death. The baby was exclusively breastfed till 6 months. After that, complementary feeding was started in the form of cereals and vegetables. So the summary is a 4-year, 6-month-old male child born to non-consanguineous married couple with insignificant family history, the birth history of meconium staining LICAR, requirement of bag mask ventilation for 4 minutes, presented with GDD, with cognitive impairment more than motor since birth, with autistic features, with fever-triggered seizure at 1 year of age, followed by onset of drug-resistant epilepsy, not responding to 3 anti-seizure medications, which is properly selected that time. It started at 1 year of age. Along with that, the child had involuntary movement in the form of choreoathetosis. So on examination, the child had normal anthropometry, had facial dysmorphism. The child was alert, oriented to parents, not making eye contact, and cranial nerve examination showing inconsistent visual tracking with athetosis of the tongue. On examination of the motor system, the child had normal bulk in bulk limbs. Their spasticity and pyramidal signs were present, and the child also had extrapyramidal symptoms in the form of dystonia and athetosis, and child also had involuntary movement in the form of distal stereotypy. The child had normal sensory examination, and cerebellus sign examination of the cerebellus sign was showing dysmetria. So these are the videos of the child. This is showing some slow athletic movement in the bilateral hands and some autistic features and stereotypy. So at this point of time, we thought of 4 possible differentials, which are succinate semialdehyde dehydrogenase deficiency, GABA transaminase deficiency, cerebral creatine deficiency, and GLUT1 deficiency. So points in favor of succinate semialdehyde dehydrogenase deficiency was epilepsy. The child had ataxia, athetosis, and expressive language delay. The child also, and point against were hyporeflexia and spasticity. Points in favor of GABA transaminase deficiency were athetosis, the child had hyperreflexia, the child also had hypersomnolence and stereotypies. And point against were spasticity, normal linear growth, and absence of regression of the milestones. Points in favor of GLUT1 deficiency were dyskinesia, drug-resistant epilepsy, and GDD, predominantly involving the cognitive milestone compared to motor. And point against, the child had normal head size, usually not seen in GLUT1 deficiency. And the child had no episodic fluctuation in relation with fasting. And the points in favor of cerebral creatine deficiency, the child had dyskinesia, epilepsy, spasticity, and hyperreflexia. Point against was the child had a hypersomnolence. So we did initial workup. The initial workup was completely normal CBC with LFT, RFT parameters, normal ammonia lactate, and TMS and GCMS. Serum prolactin was also normal. CSF routine was done, which was normal. CSF HPLC and hypocretin 1 could not be done because of financial constraint. BERA was normal. And fundus evaluation was done to rule out any optic atrophy as a part of neurodegenerative disorder, which was also showing no optic atrophy or temporal pallor of the optic disc. And skeletal survey was also normal to rule out any somatic overgrowth. And we did EEG. EEG was showing absence of normal background activity with generalized and multifocal spike and wave discharges. We also did MRI brain as a part of routine evaluation in this child, which was showing mild hyperintensity of the superior cerebellum. So based on these clinical findings and radiological findings, we thought of these 2 possible differentials, which were succinate semialdehyde deficiency and GABA transaminase deficiency. So then we thought, what could be the other possibilities in this child? Then we did review of literature, and we found that complex 1 deficiency causing leaked phenotype can sometimes cause this narcolepsy with excessive bedtime sleepiness because of progressive degeneration of the neurons in the brainstem, and as well as involving the degeneration of the neuron of the basal ganglia also. So after that, after all these investigation and clinical findings, and we thought of these 3 possible differential, which were GABA transaminase deficiency, mitochondrial deficiency, specifically complex 1 deficiency, and succinate semialdehyde dehydrogenase deficiency. So we did whole exome and mitochondrial exome sequencing, and it found that we found ABAT1 gene mutation in compound heterozygous state. We also did parental segregation analysis, which was showing the parents were carrier for the same variant in heterozygous state. There no pathogenic variant was found in the mitochondrial genome analysis. So final diagnosis was a global developmental delay with predominantly involving the cognitive milestone more than motor milestone, with drug-resistant epilepsy, with hypersomnia, with dyskinesia in the form of athetosis, stereotypy, and dystonia, so spasticity with autistic features secondary to GABA transaminase deficiency. So a brief note on GABA transaminase deficiency. It's a rare autosomal recessive disorder of GABA metabolism. Median age of onset. Okay. So this is the I've taken this image from one publication. This publication was reported in 2017. It was done by Mary K. Coing and other co-fellows. And in this study, they included 10 cases of previously diagnosed GABA transaminase deficiency. Out of them, they selected 2 cases. Among these 2 cases, they started trial with flumazenil, and they found significant improvement in the sleep span, as well as significant improvement in the severity and frequency of this dyskinesia. So these are the two images of one of these two children who has started with flumazenil trial. The first image, which is labeled as A, it was done before initiation of flumazenil therapy, just showing absence of normal background activity with the chaotic background with the multifocal and generalized spike wave discharge. And the second EEG, which is labeled as B, which was done after 5 months of therapy with flumazenil, and it is showing relatively normalization of the background, although there is no normalization of the there is no presence of posterior dominant rhythm with some persistence of the generalized epileptic discharge. So the conclusion is drug-resistant epilepsy, autistic features, dyskinesia, ataxia, hypersomnia should consider GABA-transaminase deficiency in addition to cerebral creatine or GLUT1 deficiency. GABA-transaminase deficiency, although causes neonatal or familial neonatal or infantile encephalopathy with high mortality, but milder phenotype can coexist, mimicking other neurotransmitter disorder with epilepsy. Presence of normal MRI in the setting of dyskinesia should raise the suspicion of neurotransmitter disorder. So these are all my references. Thank you.
Thanks, Dr. Amresh. Very interesting case. Your mentor, Dr. Venkataraju, any comments from your side, please?
Yeah, so usually you know that autism usually in general causes the sleep issues more in
Dr. Roy,
more in the
Dr. Amresh, stop sharing so that everybody can.
usually autism in general, drug-resistant epilepsy, most of the times you'll see commonly the sleep issues, less sleep. But in this situation with autistic feature with drug-resistant epilepsy, you have seen a case with hypersomnia. So usually the other causes you will consider is usually epileptic encephalopathy or drug reaction, but you are excluded all those things and including IEM also because of routine test and metabolic screening all are negative. So this condition should be considered whenever a child with autistic features and epilepsy with increased sleepiness. The drug plinabazine is advisable, but you are not used because of cost factor, and also there is a risk of seizure aggravation in this condition. So that is the reason you are not using this specific child.
One of those 10 patients is followed by me. The patient lives in New York and comes to see me for both the sleep and epilepsy issues. The question I asked Phil Pearl, who's now in Boston Children's, I asked Phil, do you think we can use clobazam with a GABA transaminase deficiency? And I think the data is unclear whether a benzodiazepine can be metabolized in this condition. I'm not sure. I was hesitant to use clobazam for the epilepsy part of it.
Thanks, Dr. Kothari, sir. I think nothing's a very useful session. Dr. Kothari is not there.
Dr. Biju, you want to say anything about the case?
No, interesting cases. Only thing I say is from Professor Raju's department, I've always seen fantastic cases.
Yeah. You know what? He's my go-to man to get the cases. I always call him up and he texts me, yes, ma'am, I'm ready with the case. That's really good. And very incidentally, let me tell you, Mahesh was the first pass out from this thing. And Raju is also from here. Vishrup is also from here. Ranjit is also from there. So all of them are alumni. So it gives a great pleasure to see, them doing so. And he's also sitting in clinic. Dr. Kalra was also sitting in clinic. He is also sitting in clinic. Mahesh is also sitting in clinic at 9:40, nearly 10 p.m. as well. So can you have take-home messages, Dr. Kothari? Take-home message. As customary.
If I may just indulge before I go to the take-home message, there was a question about labroscitant, which is DORA, which is a dual orexin receptor antagonist. I just want to say that I've been trying to look at this product, these DORAs, for epilepsy and sleep, because these DORAs increase REM sleep. They also are a treatment for insomnia. So in patients who have epilepsy and sleep, we can improve their insomnia by using the drug. We can increase their REM sleep, and you know that REM sleep is protective towards epilepsy. So can we have a two-edged sword where you can have both of these accomplished by using DORAs? It's something which is worth looking at in the future. And the take-home message over here is, in the autistic population, think of the problems the kid has, but more importantly, think of the perceptions of these problems from a family perspective. It's very important. Everything else has been addressed very nicely by Dr. Kotagal, and whatever other articles I've asked Dr. Gulati to share to the crowd, papers that I've published on the subject.
Already shared.
So those are my
We have already shared in the chat. Yeah.
And there's an ESCS article
Yeah.
also, which is our review article. But anyway, thank you very much for having me.
Done. Thank you. They are also been shared. I also shared that thesis. That was an MD thesis we had done on PSG in autism children. It was a nightmare getting PSG done that time. It was long back, 10 years back. Thank you. Dr. B, before that, Ambrish and Dipti, well presented. You'll be mailed your certificates. Dr. Biju.
Thank you. Excellent session, as always, Dr. Shefali, and excellent contributions by all the speakers and good presentations as well. I was just having another look at the literature today and realized that how much shortage there is in terms of the literature on sleep and autism. I think there are lots of burning questions which needs to be addressed. One thing which struck me was the role of circadian rhythm in these children, in this particular group of children, and also among these children, the ones with intellectual disability, how that differs. And I couldn't find any study. Out of interest, I was looking at it, and I couldn't find any studies at all. So there's a huge need for longitudinal studies looking at these children. And in fact, even questionnaires, we discussed few questionnaires in this talk, but applicability of even the CHSQ in the younger children, the below 4 group, and those children with autism. And I don't think all the factors in CHSQ would be applicable for children with autism. So there's a huge area for research. And I think it's up to interested people to take it forward, particularly the juniors.
Yeah, that's where the current dissertation, what we're doing is actually using actigraphy, and that actigraphy we may help to get the circadian thing also in addition. So just this thing and the scale, because we knew CSHQ doesn't work. One has to socio-culturally also different because of that sleeping with parents and all that thing. And that's why that other Vishru's student had made that Zulfi's thesis was to make. But in that you have you get to know the conditions are diagnosed. So for a screening, we have to have another one for the autism. Yes. Nitish, would you like to give your take-home message? You're moderating, so you're actively involved. Yeah.
Nice. So lots of learning than saying anything. But yes, so basics, good history, support, sleep diary, and as Dr. Kothare said, holistic approach. End of the day, I think we are there for child and family. So
I think counseling of family is important. Like Dr. Cortical said, that family never came back because that family might have not understood, because you have to understand and explain to them. And my first line to many of the parents is, you are wonderful parents. And the child has autism is not because of your, not doing something or something you could have done, like that. So that is there. That is something very important. Thank you, Nitish. Mahesh.
It's well covered, and the topic is well covered. I would like to just tell that even other factors like constipation, dental caries, they also have to be thought of. And they're very simple problems, but most of them we ignore them. So even they need to be thought of when we manage people in children autism.
Vishru? Thanks. Vishru?
Yes, ma'am. So nothing much, ma'am. I think everything has been covered. Two important things that when we look at any disorder, we should holistically look at it, because most of the times we miss out on sleep comorbidities for the simple reason that it's not looked at as a disease. It's always a comorbidity.
No, they don't come up. No, the point is many times parents don't come up with it. We have to ask for it. So we've started asking, and we're putting the questionnaire in the file, autism file.
And even from the physician's perspective, many physicians also don't ask whether they have any associated sleep problems. And most of the neurological disorders have associated sleep comorbidities. And if we address them, we are able to give a better management, irrespective of the type of the disease. So that's it from my side, ma'am. And an excellent session.
Thank you.
Excellent input from all the experts.
Thank you. Thank you. Thank you so much. And I thank everyone. Sasmita, can you show the slide once again? I would, remind you that now we were having it every 2 weeks, but we are having a session next week because of some logistics. You have the World Cerebral Palsy Day tomorrow. So next week you have Dr. Brahim talking about CP mimics, and Dr. Biju Hamid will be joining as expert, in addition to many other experts in next Wednesday. And I welcome you all for the AOCCN again next year. And yes, you do have one pre-conference whole day workshop, which is going to be by Dr. Kothari and Dr. Kotagal. So you better book yourself right away, right? Thank you so much. Maybe you can put this as video only, Asmita, and you have stopped sharing the we do it from start. It didn't start. And can you stop showing the certificates online, but you can send them, right? I hope you're sending all certificates, right?
Yes.
Yeah, thanks. You can start it, please. I thank you everyone for being there. Asmita? Asmita. It's okay. Thank you so much. See you next week and obviously next year too. Thank you so much. Bye.
Thank you.
Thank you, Nitish.
Everyone.
Thank you. Thank you, Dr. Biju. Thanks. Bye. Thank you.
Good night.
Bye. Good night.